Thanks for joining us. My name is Jack Rychik, and I'm a pediatric cardiologist at the Children's Hospital of Philadelphia. Welcome to Pediatric and Congenital Heart Talks, a series of lecture presentations and discussions on interesting and important topics in our field of pediatric and congenital heart care. In this series, we will share insights on a variety of topics, offer new perspectives on some basic principles, introduce novel concepts and innovations, as well as identify what needs to come next to solve challenging problems in our field. Our objectives are to provide education on a variety of topics, but also perhaps to stimulate some provocative thought. We'd love to hear from you and get your questions and ideas and thoughts on these discussions. You can contact us at this email address, chophearttalks@email.chop.edu. Okay, let's go ahead and get started.
Hi, I'm Joe Rossano, the Chief of Cardiology at the Children's Hospital of Philadelphia, and welcome to our Pediatric and Congenital Heart Talks. It is my pleasure today to introduce my friend and colleague, Jack Rychik, who will be giving our talk. Dr. Rychik is a cardiologist extraordinaire and plays many roles within our cardiac center. He's Associate Chief of Cardiology and Professor of Pediatrics, as well as the Director of our Fetal Heart Program, our Single Ventricle Survivorship Program, and our Fontan Forward Program. And today, we will be talking about heart care before birth. Jack?
Thanks very much, Joe. Appreciate the opportunity to chat with you over the next couple of minutes. What I'd like to present to you is the concept of treating cardiovascular conditions before birth. Give you a quick snapshot update of where we are now, but perhaps even more so, and perhaps in a bit of a provocative way, talk about where we are actually in the very near future as it relates to making these diagnoses and treating these conditions before birth. So up until about 40 years ago, what occurred prenatally was part of the black box of life, if you will. No real sense of what was going on. One could look at a maternal abdomen and notice an increase in size and girth and such, but not really get a very good sense of what was happening beneath the surface and in utero. The advent of ultrasound truly opened an entirely new window for us, an opportunity for us to observe the minute details of human development. And this has given us, in the year 2021, the opportunity to get exquisite, detailed imagery of all structures of the cardiovascular system. And this is the basis for how we make our diagnoses today of a wide variety of conditions, ranging from simple things like septal defects, simple things that perhaps we don't even know the significance of, like echo bright papillary muscles or other minute details of the heart, to complex conditions such as heterotaxy syndrome, anomalous pulmonary venous connections, et cetera, et cetera. We have an incredible ability today to really unveil what has been veiled to date and give us a tremendous sense of what's going on within the fetal cardiovascular system. Fetal echocardiography and ultrasound provides us with a toolbox, and we have our basic hammer and screwdriver and set of pliers that we use to help us to figure out what's going on. Two-dimensional imaging, color Doppler imaging, pulse wave Doppler, the advent of some additional advanced modalities that really gives us this ability to understand complex anatomical configurations, to assess blood flow patterns that may very well predict blood flow patterns postnatally and allow us to establish a plan for how we might manage these patients as soon as they're separated from placental circulation. These are features and findings that dictate strategies of care and ultimately influence outcomes for our patients. So if I looked at these sort of green-red binary dichotomous ways of assessing where we are today with fetal cardiological care in 2021. Here's how I would look at it. We have a number of tremendous advantages, as I've just described. We can accurately diagnose most forms of structural congenital heart disease. We can understand many types of conditions and comprehend their pathophysiologies. And we can take this information, we can digest it, process it, counsel families, and prepare for the delivery of these complex fetuses. But yet there are many limitations. We can offer effective treatment to only a very limited number of fetal cardiovascular conditions. So if you think of the things that we're very effective at, twin-twin transfusion syndrome, huge amount of work that's been done in the last decade, and a very, very good understanding of how laser therapy can interrupt the basis of this condition and dramatically improve outcomes for what I would consider a cardiovascular condition in a monochorionic diamniotic system and twin-twin transfusion. We can treat tachyarrhythmias, but yet with some degree of limitation because we are offering that therapy through the mother, but yet in many circumstances we can have an effective result. And then there is the concept of taking patients who have aortic stenosis and looking at their trajectory, perhaps predicting development of left ventricular non-viability, and attempting to interrupt that process through a balloon aortic valvuloplasty. Great enthusiasm for this approach early on. As with many new things, somewhat tempered of late as candidacy criteria have become more selective and we understand a bit more about the efficacy of this particular intervention. So still a lot of controversy about it, but the notion that here's a condition and basically we have the logic that tells us that perhaps intervening might make a difference is an extremely attractive notion. And that gets me to this point. We have a great desire and aspiration to expand our capacities for fetal treatment of cardiovascular conditions. Doing the imaging alone is great. We have an understanding of what's going on, but it's extremely frustrating when we have a fetus at 20 weeks with a complex condition and we see what's coming. We know what the neonatal and postnatal course is going to be for that particular fetus, but yet our hands are tied at the point of that initial diagnosis in not being able to do what we would like to be able to do, which is to in some way manipulate the circulation, in some way alter the conditions to improve outcome. Prenatal therapies, in fact, as we know, may offer better opportunities for effective therapy than postnatal strategies, simply because of the plasticity of the fetus and the ability of cells and organs to adapt to new conditions. So on the one hand, we have the ability to diagnose. We understand that prenatal life is an important and very influential period of human development where we might be able to importantly affect these anomalies, but yet we're limited in our ability to do so. So this gets me to where I think we need to be and where I think the field is heading. We need to finally take advantage of the opportunities afforded by fetal plasticity and begin to look at how we can change the substrate and the outcomes for our patients with congenital heart disease. So let me start with an example of what can be done today, which to a degree also highlights some of the things that I'm pointing out, which relates to our limitations from a prenatal interventional perspective. So here's a case that we saw a couple of years ago, not too long ago. It's a fetus that presented at about 20 weeks gestation. And what you see here, see if I can get my arrow to come up. Yep. So here you have evidence of cardiomegaly. This is about 20 weeks gestation, a dilated left ventricle, dilated right ventricle. 4 chambers of the heart are there. But as we look a little bit more closely with color Doppler, what you see here, I'm pointing this out, is the ductus arteriosus. Now, the ductus arteriosus is this red jet. It's retrograde. Now, typically, ductal flow is retrograde when you have obstruction to pulmonary blood flow and a need to support the pulmonary circulation in some manner. But that's not what's happening here. Take a little bit of a closer look here now at the atria, and what you see, in fact, is a gigantic left atrium and a massively dilated right pulmonary vein. It's almost as if somebody took a bite out of the lung here, but in fact, this is part of the left atrial cavity. And as we put some color on in the lung, what you see here is really a very unusual, fascinating, and quite rare condition. There is a connection that exists between the right pulmonary artery, right pulmonary vein, before the vessels enter the hilum, or just at the hilum of the lung. And this is a pulmonary arteriovenous fistula. And here you see more of a close-up look at this. And here we're looking at the fistulous connection. This is the pulmonary artery, pulmonary vein. And what's happening is the blood is bypassing the right lung parenchyma, finding the pathway of least resistance, and draining back to the left atrium. So there are a couple of physiological manifestations here. Prenatally, there's a giant volume load that is taking place because this is functioning like an AVM, like an arteriovenous malformation. And in addition, we are shortchanging the blood flow to the right lung, potentially altering pulmonary vascular development in the right lung. Here you see some Doppler of that connection, very high velocity continuous flow, and a massive amount of return through the right pulmonary vein. So in this little cartoon here, I'm demonstrating the physiological effect of having this bypass connection. When you have a pulmonary arteriovenous fistula, you are directing pulmonary arterial blood flow away from the lung parenchyma to the pathway of least resistance to this connection to the pulmonary vein, thus resulting in cardiomegaly, a volume load to the fetus, the potential for fetal heart failure, development of hydrops. But postnatally, this has an even more important consequence. And because pulmonary blood flow, which is desaturated, has to get into the lung parenchyma for adequate oxygenation. If you have a bypass pathway that will take that blue blood and shunt it into the pink side, into the saturated side, you have the opportunity here for a severe degree of desaturation and hypoxia. And what's been reported for these large pulmonary arteriovenous fistulae is if they exist early in life, that one has the potential for severe hypoxemia and death. So here we are. We identify this particular lesion in this patient. And so prenatal diagnosis, 22 weeks. Could we do something prenatally? Science fiction, probably at this point, but we thought about it for a bit of time. But at the very least, we knew that we would need to intervene on this fetus as soon as it was delivered, as soon as it was born. So that's the best that we could do, so that's what we prepared for. We did something that in our institution we refer to as an IMPACT procedure, which stands for immediate postpartum access to cardiac therapy, where a cesarean section is performed in a room adjacent to the cardiac catheterization laboratory. And our strategy was for a rapid evaluation of this newborn as soon as it was separated from placental circulation, rapid access into the circulation with the potential for deployment of a device in the fistula. And so here, we undertook that procedure. We delivered this baby through a C-section at 39 weeks, quickly taken into the cath lab. Here's the echo that was performed while we were obtaining access to be able to deploy a device. And what you can see here is, just from this 4-chamber view, this torrential pulmonary venous return from the pulmonary artery connection. And in fact, the blood gases that were obtained in the first moments of life confirmed a severe degree of hypoxia, pulse oximeter saturations in the 60% range, with acidosis that developed. Within about 20 minutes, we were able to gain access, and here you see the initial angiogram, the catheter in the right pulmonary artery, actually in the fistula, partially trying to occlude the fistula, but this tells you how big that connection was. You still see blood flow making its way around the balloon with a huge pulmonary artery to pulmonary vein shunt. And in the adjacent still frame, you see the occluder device, an ambulatory vascular plug, which now is fully closing off the connection. And as this occurred, you could hear that tone of the pulse oximeter just increasing up to a saturation of about 90% within the first few moments. Here's a quick echo that we did once the device was deployed, fully occluding the fistula. And you can make it out here. You can actually see it dangling through the dilated right pulmonary vein into the left atrium. There's also what looks to be an atrial septal defect, and this is probably just a consequence of the dilation of the left atrium due to the volume load. And here you see with the color that torrential blood flow is now impeded, and we've now fully closed off the fistula. And here's this little girl now at almost 2 years of age. So point being, we can take fetal information, we can digest it, we can make a plan for what needs to happen weeks after the diagnosis with an immediate intervention that results in a life-saving therapy for this rare condition that perhaps we don't see every day, but we understood the pathophysiology and we were able to act upon it. So a very satisfying outcome because we can offer therapy. Now, what about the future? Where are we heading? So let me sort of raise these questions that I sort of intimated at the beginning of the talk here. And the questions about the future are the following. What can we do to improve detection and treatment of cardiovascular conditions in the fetus? And what can we do in fetal life that will produce an improved substrate for better outcomes in postnatal life? I want to touch on 3 areas that I think are the very near future for where we're going with fetal cardiology. First, early trimester imaging, characterization of the fetal placental axis, and this notion of potentially altering the platform for prenatal support through an artificial placenta. First, let's talk about early first trimester imaging. We now do understand which fetuses are at risk, at some degree of risk, with an increased tendency and likelihood, potentially, for benefiting from early fetal imaging. But in addition, there are maternal profiles and additional biomarkers that can help us understand who might be at increased risk and therefore would be deserving of first trimester imaging. An increased nuchal translucency, which is now done routinely by our obstetrical community at 12 weeks gestation. Family history with a high risk, such as left-sided heart disease or X-linked heterotaxy. And the growing understanding of maternal metabolic risks that increase the risk for fetal congenital heart disease. MTHFR deficiency is one, but there are a host of others that are emerging now that give us a sense that something different in the mother may impact placental and fetal development to the extent that it increases risk and need for early scanning. And the technology exists for us to do that early scanning. We can get very good looks at the fetal heart as early as 12 to 13 weeks. Now, this is a study from about 12 weeks. The arrow is pointing to an increased nuchal translucency in this fetus. And then we focus in on the heart. We have a reasonable look here at the 4 chambers of the heart. And I think you can make out the fact that it looks like there's a common valve, or at least positioning of the left AV and right AV valve at a similar plane with a fairly large gap within the atrial septum. And then we now begin to look at the outflow tracts. Again, this is at about 12 weeks gestation. And the arrow here is pointing to a large vessel that's arising from the heart and a septal defect sitting beneath it. And then in a bit of more of a short axis view, what you see here is the arrow pointing to the conal septum, which is deviated anteriorly. So now we begin to put these pieces of the puzzle together, an increased nuchal translucency, a single valve that may be a common AV valve, a large aorta that's overriding a septal defect, and a conal septum that's malaligned anteriorly. So this is tetralogy of Fallot with AV canal defect, and realizing the high association with Down syndrome, the next step here would be an amniocentesis and confirmation of that particular finding, and in fact, that was the case here. So you see how we take these pieces of information and we put them together into the puzzle that begins to answer for us what is going on and what the situation is, even as early as 12 weeks gestation, which is an incredibly valuable piece of information for our families. I would venture to say that this should be our goal. And I don't think there's any reason why, with technology today, we shouldn't be able to begin to focus on this. Completion of cardiovascular development takes place in the human at about 50 days, 7 to 8 weeks of gestation. If we can get this degree of clarity at 12 weeks, we should be moving towards earlier and earlier identification of different structures, and the technology does exist for us to do that. This is where we're moving. Next, another important factor that is associated with congenital heart disease, and one that is generating a fair amount of interest, is characterization of the fetal placental axis. Now, we know that the placenta is a critically important structure. The NIH has come up with this statement: it's the least understood human organ, and arguably one of the more important, not only for the health of a woman and her fetus, but also for the lifelong health of both. It's one of the only human organs, in fact, the only human organ, that one can regularly grow as new, discard, and then grow again, which is done by women who carry gestations to term. What we know as well is that the timing of the development of the fetal cardiovascular system takes place at about the same time as placental vascular development. And there are a number of pro-angiogenic genes that are shared between these two structures, the fetal cardiovascular system and the placenta. Other data that's emerging suggests that there is a clear association as well between abnormalities of placental vascular development manifest as preeclampsia and maternal hypertension, and the presence of congenital heart disease as well. Again, further suggesting a commonality between these two. So not too long ago, we wanted to ask some very basic, simple questions within our own group, which is, what do the placentas look like in our patients with congenital heart disease? So this is some work that we published about 3 years ago, simply looking at placental weight to birth weight ratio in our newborns with congenital heart disease born in our delivery unit at CHOP. And what you see in red here is the normal mean and 95% confidence intervals for the placental weight to birth weight ratio. And when we looked at 120 fetuses with a variety of complex congenital heart disease, this is where their placentas are. In fact, more than half were below the 95% confidence interval for what we'd expect it to be normal. So we know that fetuses with congenital heart disease may be small, but even so, the placental to birth weight ratio was lower than normal, accounting for the small size of the fetus. When we begin to look at the pathology and the histopathology of these patients, what we see is that thrombosis occurs in about a little over 40%. 20% had evidence of clear-cut infarction, typically in the watershed regions of the placenta. And when one begins to look at the histopathology, chorangiosis, which is defined as an increase in capillary density per region of villi, cotyledons within the placenta, that was present in about 20% of our patients. So what do we know about saturations, oxygen saturations in the fetal cardiovascular system? This is work done by Mike Seed in Toronto using sophisticated MRI techniques that have allowed us to actually quantify saturations in different portions of the fetal cardiovascular system. And what he did was he looked at umbilical vein saturations, which you see here comparing congenital heart disease to normal. And what he found was in the congenital heart disease patients, umbilical vein saturations were lower than normal. Now, if you think about this, if you have congenital heart disease and a structural malformation downstream, why would that influence what's happening to the saturation of blood coming out of the placenta? It should not. And so therefore, what's happening here is there must be something that's different about the placenta that's altering the oxygen saturation in umbilical venous flow. Now, we've started to begin to look at this in our group here at CHOP. We've been interested in trying to use the various tools of ultrasound to assess placental blood flow. And here what you see is looking at uterine artery flow, which is something we typically do in all of our patients. And maternal uterine artery flow reflects what's going on in the maternal circulation. It's important because that contributes to the placenta as well. And in a more typical conventional manner, one can use ultrasound to assess the umbilical arterial flow and obtain particular flow patterns that are helpful in understanding what's going on. But we decided to take this to a little bit of a different level and begin to look at umbilical venous volume flow. So although the resistances of flow to the placenta from mother or fetus might be altered, getting this additional information about the actual quantity of blood flow emerging from the placenta by measuring umbilical vein flow, we thought would be helpful in perhaps beginning to understand in vivo during the fetal life as to how some of these differences are manifest between normal and congenital heart disease. So this is work that Deb Ho, one of our former fellows, did, where we looked at 171 normals, compared it to 82 fetuses with congenital heart disease. This at about 26 to 32 weeks gestation. And we found that umbilical venous volume flow was significantly lower in our congenital heart disease patients, as well as umbilical venous volume flow that was indexed to combined cardiac output was lower in our patients with congenital heart disease. Now, what else can we do? There's some other sophisticated tools that are being developed that can perhaps allow us to directly image the vasculature of the placenta and to quantify the degree of vascularity. So this is some new technology that's been developed, something called MV flow, that can allow us to evaluate small vessels and very low blood flow velocities. And this is what this looks like. One can assess the vasculature here in the placenta, and this is a comparison done to a postnatal state, modeling the vasculature. And one can assess different regions of the placenta and begin to, both qualitatively and in a semi-quantitative manner, evaluate the degree of vascularity in a particular region of biological tissue. And what we did in this particular study, and this is a collaboration between a group in China and our center at CHOP, is we looked at a series of normal fetuses and then some fetuses with fetal growth restriction to just in a dichotomous way see if there was a difference in the vascularity. And lo and behold, not surprisingly, as we would expect, what you see here are the normal vascular patterns in a very nice tree-like manner with normal branching and bifurcation, and a very limited vascular pattern in our patients with fetal growth restriction. And then in this semi-quantitative way, using a vascularity index, we looked at different regions of the placenta to look at whether there might be differences in vascularity in a normal group of patients between different parts of the placenta itself in the middle, upper, and lower portions, and noted no difference in this vascularity index when looking at normal placentas, validating the methodology, if you will. And then we looked at the vascularity indexes in our patients with fetal growth restriction and a control group, and there were significant differences in this quantitative manner. So this is work in progress. We now have a study underway where we're looking at this in our patients with congenital heart disease to see if there might be differences in vascularity between those with congenital heart disease and a normal placenta. And then finally, is there the possibility that we might be able to alter the platform for prenatal support? So let me share with you some work that's being done, and this is primarily the work of Alan Flake and our fetal surgical team here at CHOP, where for the past few years, through multiple iterations, the group has been developing a technique to allow for survival in a ex utero manner, but yet where we're mimicking the uterine environment. So this is at the moment in the fetal lamb model, and what you see here is the diagram of how this is undertaken. These animals are exteriorized at about 95 to 100 days of gestation, equivalent to about 20, 22 weeks in the human, and placed in a sterile biobag with amniotic fluid that makes its way through the bag itself. And the umbilical artery and the umbilical vein is cannulated and connected to a very low resistance oxygenator. So in essence, the drive for blood is the fetal heart itself in the fetal lamb, and oxygenation takes place through this low resistance specially designed oxygenator where we can control the sweep gases, and one can also control nutrition and other vascular aspects through administration of prostaglandin and such. And we've been able to take this model, develop to the point where we have an extremely sustainable system that allows for these animals to thrive and grow. Here, let me show you a quick video of one of our animals. And this one was involved in a particular study that lasted for 28 days. You can see the lamb moving. You can see the cannulae. And here's the animal again in the sterile biobag fluid, undergoing normal development. And this particular animal in this experiment was a survival model, made it to term. And here you see the animal moving around, doing everything you would expect it normally to do. And of course, we're undertaking a series of studies to look at brain development, and in particular, our area of interest here, looking at heart development. And so we've been imaging these patients, these fetal sheep, on a regular basis. And here you see my colleague, Dr. Zhiyu Tian, from the Fetal Heart Program. We have protocols in place to look at fetal development in these lambs. And what we're finding is essentially information that's pretty close to what you would normally expect. There's good maintenance of the fetal circulation in these animals. And we're able to calculate outputs by looking at left ventricular flow and right ventricular flow, and looking at the ratio of combined cardiac output, as well as assessments of right ventricular output and left ventricular output. And these are essentially tracking what we would expect to normally see with normal fetal development. Some work that we published a little over a year ago looking at some more sophisticated means of myocardial contractility in these fetal patients, and noticed, in fact, interestingly, that as these animals jump on the system early on, there's a slight decrease in their longitudinal strain, which then normalizes back within week 2 and week 3, once on the system itself. So again, there's a bit of an adaptation, and certainly as we take these concepts and bring them to human care, this is something that will be important for us to look at and monitor in our humans. And this data is being presented to the FDA and in a rolling manner is undergoing evaluation, with the hope that perhaps within the next few months we'll have the opportunity to begin to explore this in the human. Now, just imagine how this could be employed potentially as it relates to many of the things that we as fetal cardiologists deal with on a regular basis. Here are some of the dilemmas where this might play an important role. Imagine a 24-weeker with placental insufficiency and growth restriction and abnormal umbilical arterial Dopplers. Right? That's a condition we know, unfortunately, has a very, very poor outcome. Imagine a fetus at 28 weeks gestation with hypoplastic left heart syndrome, ruptured membranes, and impending delivery. That period of time between 26, 28 weeks, premature infant with complex single ventricle, extremely poor outcomes for that particular category of patients. A 30-weeker with SVT and hydrops that's unresponsive to maternal drug therapy and that we might need to consider an early delivery for. Or a 32-weeker with Epstein's anomaly and severe hydrops. Again, all of these are conditions that we know have extremely poor outcomes. Now imagine if we could take these situations and continue to support these fetuses for a 2, 4, 6, or 8-week period of time in an in utero environment and continue in utero development, we have an opportunity here to improve the outcomes for these otherwise very poor outcome conditions. And to do so in a way in which we can also potentially manipulate the circulation and directly treat these fetuses in this little ICU-type setting, if you will. So it's a new solution, a new paradigm of care, and one that I think is just around the corner for these patients. So to close, fetal cardiovascular care, where will we be in the very near future? I believe we will be imaging the fetal heart at 10 to 12 weeks gestation. Fetal cardiovascular assessment will include tools to allow for accurate characterization of the health of the placenta, which is going to be an important thing to incorporate. We will be able to support prenatal life through an exteriorized system with artificial placental support that will allow for a host of new therapeutic opportunities. And we will be able to expand our capacities for fetal cardiovascular treatment for management of not just fetal conditions, but with the intent also to improve on long-term outcomes for cardiovascular conditions in general. Again, taking advantage of this opportunity of fetal plasticity. Thanks very much for your attention.
Jack, thank you. That was a wonderful talk and incredibly exciting things that are going on. When you look into your crystal ball, and you mentioned science fiction in your talk, and what seems that would have been science fiction 5 years ago is almost the reality today. And so when you look ahead a little bit into the future, what do you see as the future of fetal heart care?
Well, I would break it down into sort of near future and future. I think there are things that we can do right now. I'm often asked sort of, to offer a vision of what a future looks like for the work that we're doing. Probably the first way to respond to that is to say instead of kind of trying to predict what the future is going to be like, we need to create that future. And certainly for near future, there are things that we can do to kind of push things along. So in the very near future, I would really imagine that we're going to be altering the set of evaluations that we undertake for our patients. By that I mean, right now, we grab some ultrasound gel and we have a skilled sonographer or a skilled physician, and we hit the buttons on the machine and we focus on the heart. And we look at the structure of the heart and, again, can make exquisite diagnoses, tremendous detail, and get a really good sense of what's going on. But I think the assessment of the future, near future, will include a much more comprehensive evaluation. First, it will take place much, much earlier in gestation. And I do think that at first trimester, we'll be able to have the capacity to do many of the things that we're doing now in our second and third trimester. So the timing will be very different. We'll have a much clearer understanding of who is at risk and bringing those mothers in at an earlier point in time. But the assessment will go beyond just the heart itself. The assessment will include the placenta and has to include the host. I think there's an important axis relationship here between the host, the mother's circulation, and the fetal circulation. And as cardiovascular experts, folks that are looking just at the fetal health and sort of being lined up to care for these fetuses in the postnatal period as well, we can't ignore the importance of the host and what's going on in that particular environment. Because I think, again, we're learning critically important that there is a hand-glove relationship, a hand-glove association between what's going on in the placenta and the maternal circulation that is influencing what's going on within the fetal circulation itself. So tools like simple things, looking at uterine artery, is something we should be incorporating into our fetal echocardiograms. And looking at the cascade of changes in flow and resistances as we look at different vascular circuits. The fetal cerebral circulation has a pretty well-defined set of indices that we should anticipate in a normal state, as does the placenta when looking at the umbilical artery, as does the maternal uterine artery. When we have aberrations, when we have congenital heart disease, the ratio of those resistances are different. And that's a simple tool I think we begin to do even right now, to begin to look at that as a general sense of either wellness or unwellness of the balance of the circulations that's contributing. So I think, again, looking at things like that, that places the fetus within a context of the maternal health is going to be critically important, and those tools exist for us to do that in the very near future. As it relates to sort of more distant future, we've got some more work to do with therapeutics. And I do feel that we are definitely heading into that direction. You know, the work that's been done around the world in catheter interventions has been incredibly exciting. And some of it has been very, very helpful and useful. Much of it, very much lessons learned. But what it's done is it's broken the ice for us to say, this barrier of you can only diagnose and you can't treat prenatally has been broken by virtue of the fact that we are now able to stick needles and catheters into the heart and affect and change anatomical conditions. We're going to be able to do that in a much finer and more sophisticated and a much better, well-understood way in the not-too-distant future. And in particular, if we can combine what I've just talked about in terms of some of the support measures, being able to replace the placenta and support a fetus ex utero, but still with fetal circulatory physiology in place, we have the opportunity to manipulate things to the same way that we do in the postnatal state, either through catheters, through medications, or potentially even through surgical interventions.
Yeah, it's fascinating and exciting. Just one follow-up question to that. You mentioned the importance of the placenta and how that's been overlooked by investigators for quite a long time. Do you envision, in addition to the artificial placenta, other therapeutics or devices for the maternal placenta that may be helpful for children with congenital heart disease?
Sure. So we know the placenta is an extremely vascular organ, and we have a host of agents that are vasoactive that we use either in the child or in the mature adult. The problem here is that we haven't studied them to date within the placental circulation. So, for example, some excitement recently that was perhaps a bit premature, but some excitement about the use of PDE5 inhibition in fetal disorders, growth restriction, and placental insufficiency, and a trial not too long ago undertaken by our neonatology colleagues where sildenafil was utilized to improve growth restriction and such. And unfortunately, the outcomes were not very good in that circumstance. It sort of, again, highlights for me the fact that, yeah, there are plenty of agents that we should be exploring, but that there is a uniqueness to the placental circulation that we still don't fully understand. And there are a host of agents that we could potentially use, but we do need to understand the substrate to a better degree. Now, the other thing, again, to begin to appreciate is we need to understand the normal state, accepting as well that we have a model of vascular aberration, which is congenital heart disease, and understanding how the congenital heart disease is associated with and influences what we're seeing in the placental aberration is still a huge unknown as well. We need to develop better animal models that can help us understand that. But I do think that, to answer your question, that we will be delving into the use of vasoactive agents to alter placental blood flow in the not too distant future.
Thanks. And maybe to shift gears a little bit, many people in our community know you and for all the great work that you've done, but people may not know other aspects about you, like what a great colleague you are, how you've been able to build such great teams, and how you've been a role model and mentor for so many people. Could you talk a little bit about, so how did that develop in you? Where did that come from, the ability to bring people together, to help people out, to build great teams, to be a trusted and supportive colleague? Where does that come from in Jack Rychik?
Yeah. So that gets perhaps to a little bit of trying to understand how each of us get to our own points in our careers. And first, I would love to take this opportunity. I think it's a great question, Joe, and take this opportunity to sort of express my gratitude for where I am in my own state of professional life as well as personal life. I think many of us in our field today, we're given this tremendous opportunity of existing in an academic realm where we can use our minds and our thoughts to create things and to have a group of people and an environment and a team of people that can help you actualize on those notions. But how does one get to this point of sort of having ambition, of having motivation, the notion of resilience, all features and factors I think that contribute to a successful career, be it in science, medicine, or any of the other domains. It's a bit of a cliche, but I do think it's true. It relates to who you are from the tenets of how you've grown up and your foundations. I do believe that in the same way that each of us sort of have our own DNA that signals molecular development and cellular function, there's something called a social DNA, if you will, that events in your life, program behaviors on a more physiological manner, perhaps neuronal network connections are formed early in life that then set the stage for who you are as an adult. For me, the thing to share is that I'm sort of a first generation, perhaps not even a first generation American, because frankly, I was born out of this country. I was born in Israel. I am the child of Holocaust survivors. And my parents did not have any opportunity at all for the educational opportunities that have been offered to me. And so hard for me to imagine, how they struggled. But I grew up with the stories of struggling for your next meal, struggling knowing where one would sleep. My dad, who's still alive, actually has this interesting joke. He would say, he would tell people, sleep quickly, we need the pillow. Which is sort of, if you only had one pillow to share amongst, a family, get done with it so that I can go next, sort of thing. But it reflects, a different period of time, in history and in life and such. And this was very, very much part of my upbringing. Maybe too much, but very much part of my brother and my upbringing. My parents didn't speak much English when I was growing up either, and so here I am, 5-year-old going to kindergarten, and my language at home was mostly Yiddish and Hebrew. And I show up first day at school, kindergarten. I remember this so vividly. Teacher would go around the classroom, ask everybody's name. Richard, Patrick, Joseph. Got to me, and my name was Yankel. So teacher kind of looked at me and said, Yankel? And I said, yeah, that's my name. And she said, no. That's not going to work. Your name is Jack. And I went home that day, told my mom, my name is Jack. Jack? And that's my name. And that's how it is. It's been, so my birth certificate again is in Hebrew. It does not say Jack on it, but my Social Security card does say Jack. So, and that became my official name. My grandmother looked at my brother and I and kind of said, you're going to be the doctor, you're going to be the lawyer. Again, when I was about 4 or 5 years of age, and that's what happened. The way I learned my English, the way my parents learned their English as well was, this is back in the 1960s, where television played a key role in your life, both as a babysitter and as an educator. And during the daytime, what's on TV but soap operas, right? Days of Our Lives, General Hospital. And the only thing you could ever become was either a doctor or a gangster, because those are the two characters that were on the soap operas. And so my mother said, no, gangster is not going to work. So you'll become a doctor. And that's, these things, I think for each of us, we have our own histories and our own stories that bring us to where we are with that. And so for me, there's this background of struggle, background of sort of getting to the next meal and survival. The stories of that, but yet my own growing up was in no way close to that, and I had really everything I needed. And my parents did everything for me that they possibly could to provide for my success. But then I worry about the next generation, right? So there's our kids, right? So this is what's contributed to my formation and how I play and perhaps my drive and motivation. And my kids look at that and say, that's too much. That is, maybe that's not for me. Now my kids are great. They've all gone to college and have fantastic careers and are set on their lives and continuing their education as well. And that's certainly something important that we've instilled in them. But the sense of urgency, the sense of distress that existed perhaps for me in looking at my parents and their real anxiety and worry about day-to-day life and where, even though they had what they needed, the life that they had led during the Holocaust and the stories that they had left an important imprint on me and is part of my social DNA. So I think that to a degree has contributed to the sense of mission that perhaps I have. And I don't want to overstate it too much. It doesn't dictate too much of what I do. But in the background, there's a sense of importance of achieving things and of being successful. And one of the ways to do that is to bring teams together, people together, to share a mission. I think I'm often quite passionate about the things that I want to achieve, and by exhibiting and sharing that passion, it brings others along. But the drive to achieve those things, I think, was set early in my life.
Well, that's great, Jack. It's a wonderful story and a lot of wisdom in there. And thank you for sharing that and for your wonderful talk.
Thanks, Joe. Thanks for the opportunity. Thanks so much for joining us. We are very much interested in your feedback, and we'd love to hear questions concerning our content that you've heard, as well as suggestions for additional topics that would be of interest to have reviewed in depth and discussed. In order to communicate with us, we have a dedicated email address. It's chophearttalks@email.chop.edu. We'd appreciate hearing from you. We'd love to hear your ideas and suggestions. Thanks so much for your attention.